All right, welcome back, everyone. I've added a note in the chat, but I'll quickly mention it here as well. And that is that the remaining sessions will be presented in English. So to listen in English, you can click the interpretation icon and select original audio in brackets, interpretation off. And to listen in French, please select French and mute original audio. We will now begin our second panel of the day, titled Vector-Borne Diseases and Climate Change. What are the risks to the health of Canadians? Welcome, panelists.
Well, thank you so much for tuning in to this very exciting panel discussion. We've got a couple of excellent experts to navigate how we're going to address the emerging threat, or maybe it's already here. We'll see with what our experts say of vector-borne diseases and the impact of climate change and vice versa. What are the risks to Canadians? So my name is Ajit Johal. I'll be hosting and moderating this session. I'm a pharmacist from Vancouver, British Columbia. I also have a not-for-profit organization called Immunize.io, where I do global work to support global vaccination initiatives. And I'm also an avid practitioner of travel medicine. I have a network of travel vaccination clinics here in British Columbia. So before I introduce my esteemed panelists, I just want to give a brief rundown of what we're going to discuss today. And before we introduce our panelists, basically we're going to talk about what is a vector. We're going to look at the impact of climate change on vector distribution locally and globally. We're going to look at two vectors in particular, mosquitoes and ticks. And then we're going to look at the impact on Canadians domestically. So if you're living here, we're also going to look at the impact on Canadians when they travel abroad. And then we're going to finish off and have some comments on the current and future interventions and strategies and how we can address this issue. So without further ado, I want to pass it over to each of our panelists to introduce themselves and also disclose a fun fact. And I will not let myself off the hook on this one. I did introduce myself, but the fun fact is I used to be a competitive tennis player. So if healthcare didn't work out for me, I hope I would have been a professional tennis player in another life. And I still play today. I still enjoy the game. So without further ado, let's introduce our first panelist, Dr. Nick Ogden.
Hi, thanks, Ajit. I'm Nick Ogden, Director of Public Health Risk Sciences in the National Microbiology Laboratory in the Public Health Agency of Canada. And I undertake research on vector-borne diseases, including impacts of climate change, and understanding how to kind of respond to these in the concept of adaptation to the health impacts of climate change. And fun fact about me, I'm a pretty avid guitar player. Not very good, but enthusiastic.
Enthusiasm is all we need. Thank you, Dr. Ogden. We're happy to have you here today. Over to you, Dr. Steve Schofield.
Thanks, Ajit. I want to clarify, you have two experts and esteemed people on the panel and me. So I work for Defense. I'm a senior scientific advisor in a group called Communicable Disease Control. Among other things, what we do is when we send people overseas, we're the group that will think about what vaccinations we ought to use, what other mitigation strategies, repellents, food and water, etc., we ought to use for personnel deploying to, say, Africa, South America, Asia, Eastern Europe right now, as a matter of fact. Developed a policy related to that. I'm very fortunate in that I've been part of the Committee Advising Tropical Medicine and Travel in Canada for, I guess it's about 20 years now, and they elaborate clinical practice guidelines. I've been on a few working groups for ACIP and for NACI as well. Fun fact, and you're going to have to ask for details, and you know, if you want them throughout this webinar, is that I once wrestled a pig while wearing Lycra.
I think that might be an overshare. I think we'll kind of stop there. Thank you, Dr. Schofield. And then, of course, fellow pharmacist, Tracy Phillips.
Hi, Ajit. Thank you. Yeah, so I am a pharmacist. I've been a pharmacist for more than 30 years. I've spent most of my career in the Toronto area, and I, before retiring, was the vice president of pharmacy for a large national chain, where what my role was essentially helping pharmacists operationally and professionally implement their scope of practices as they expanded across the various provinces. Yeah, after my retirement, in air quotes, I was very fortunate to move to the small community where I live in Westport, Ontario, which is a little bit north of Kingston and west of Ottawa, in a rural area full of ticks, endemic for Lyme, hence my participation, I think, today, and be able to have the opportunity to purchase the independent pharmacy here in our village, and went back to primary care, which has just been a joy these past 10 years. So fun fact about me, I am an avid outdoors person. I am a dive master. I ride a motorcycle, and I'm a pretty good snowboarder in the pipe. So
Perfect. Well, really appreciate having you here. And I think your operational expertise on scope of practice will definitely be highlighted at the end of the discussion. So as you can see, we have a very diverse set of experts, as well as diverse fun facts. So this will certainly make for a very engaging and hopefully provocative discussion. So I will kick things off with some very basic definition. And this is a panel on vector-borne diseases and climate change. So what is a vector? And vectors, unfortunately for me, I was introduced vectors in grade 11 when we started with physics. And this is a different type of vector. This is one which it's a living organism that can transmit an infectious pathogen between humans or from animals to humans. And vectors, of course, can be different organisms, and they can also carry different pathogens. So you can see here, there's quite a different number of vectors that we're seeing on this table, and also different pathogens that they can actually transmit to humans. So even within a mosquito, there's different species of mosquitoes. You can see the Aedes mosquito, which transmits a lot of vector-borne viruses as well as parasites. And then the Anopheles mosquito, which of course is really well known, evening biting mosquito that can transmit malaria, which is a parasite. And then the Culex mosquito, which can transmit viruses like West Nile and Japanese encephalitis. So one thing to know here is that even within a single species like a mosquito, different subspecies and different taxonomy can transmit different diseases. And that has big implications when we look at climate change and seeing where these pesky organisms can now live and breed. And of course, if they bite and infect humans, different pathogens, of course, can make people sick. So the big ones we're going to focus on today are mosquitoes and ticks. So that brings me to my first question for Dr. Stephen Schofield is, climate change and the emergence of vector-borne illnesses. What have we seen locally and what have we seen globally? Oh, Dr. Schofield, you are on mute. I'm always afraid of that. That's why I never put myself on mute in the first place. So as we wait for Dr. Schofield to come off mute, Dr. Ogden, do you want to take a swing at this?
Yeah, sure. Clearly, we've seen a lot of evidence of emergence and re-emergence of vector-borne diseases. We've seen epidemics of Zika and yellow fever in South America. We have evidently a lot of ongoing endemic vector-borne disease illnesses around the world. Malaria, dengue, Zika, chikungunya are the main ones as far as mosquito-borne diseases. to what extent there can be attributed, or the emergence and re-emergence of these can be attributed to climate change, is very much in debate. And I think in most cases, there is not strong evidence that climate change has actually driven those events, even though it may well have done. That we're limited pretty much to the impacts on diseases for which we've got a lot of long-term surveillance, and that includes the malaria in the African highlands, where there's now pretty solid evidence, I think, that this malaria is kind of heading up the mountains into places which were once too cold for it, and that has been driven by recent climate warming that is attributable to human activity. And perhaps one of the others that is the emergence of Lyme disease in Canada. And I think we've not got some pretty strong evidence that climate change, and anthropogenic climate change, the recent warming has driven permitted the emergence of populations of the Lyme disease vector, the black-legged tick.
Great. No, thank you for that explanation. And we'll definitely get into the Lyme disease story here in Canada in our next discussion. Dr. Schofield, have you gone off mute?
Oh, well, I hope so. I wasn't on mute. My microphone stopped working. And so I panicked, and it seems to be working again. One, I agree with Nick. And actually, that was intentional because he's smarter than me, so I'm always going to let him go first. But I want to look back in history a little bit. And I think this is informative. We're going to talk about Aedes aegypti today, which is the yellow fever mosquito. It is the mosquito that drives things like dengue around the world, probably 400 million infections with dengue annually in the world. Dengue is a new phenomenon in the last, let's say, 500 to 1,000 years. Aedes aegypti does so very well because it's hitched its horse to us as humans. It lives in urban environments. It hangs out in man-made water receptacles, etc. I think the current thinking is that it used to be more of a quasi-rural mosquito. And with the drying of the Sahara, so climate change hitched its horse to humans. And consequently, as we moved around, so did it. So we exported it to the Americas, et cetera. But it's actually a climate change example from the past that's incredibly important today. So I think that's something to think about and something that's informative.
Perfect. Well, thank you so much for your explanation. So, with this sort of, when we're seeing these vector-borne diseases pop up in areas that they haven't been before, for example, in southern France, this is the statement from, I believe it's the London School of Tropical Medicine and Hygiene: cutting in CO2 emissions will be needed to avoid increasing parts of Europe becoming vulnerable to dengue. Of course, Dr. Schofield will have you present in a little bit to maybe perhaps give another sort of perspective on that. And you also gave this data of malaria in Maryland, United States. Do you care to comment on, why we're seeing this pop up in North America? Because we heard Dr. Ogden talk about Western Africa, where we really look at P. falciparum malaria and high transmission. Why are we seeing this closer to home?
I think it's complicated, number one. I think Nick provided a good summary that actually tying things explicitly and exclusively to climate change is difficult at this point. And maybe always will be in some ways, because these things are complicated. And it is absolutely the case that malaria on occasion has reared its head in terms of autochthonous transmission in the United States over the last 20 or 100 years. Indeed, malaria has only been eliminated from the United States in the last 100 years. So this is more a reintroduction than anything else, but it is absolutely the case, and perhaps I should have mentioned this earlier, that irrespective of the overall changes in climate with time, I think variability can be higher these days, and hence we can have situations where it's a bit warmer, there's more water that can enhance dengue transmission in South America, as it did recently. And it may contribute to, for example, but local transmission of malaria, very small clusters, to be fair, in areas that are permissive in terms of mosquitoes, because the mosquitoes are already there, and areas that are permissive in terms of the actual the parasite itself, the malaria parasite, in terms of developing the mosquitoes and being passed to someone else. The reality is in most of these areas, because we have screens in our windows and the vector isn't particularly good, and we have air conditioning, the likelihood of substantial transmission, at least at this point, is probably pretty low.
Great. Well, thank you for the explanation. Let's move to Canada. So this was a paper in 2019. Could exotic mosquito-borne diseases emerge in Canada with climate change? And even if they don't take hold, as you mentioned, Dr. Schofield, just having them pop up, is that a possibility? So I guess to Dr. Ogden, could exotic-borne mosquitoes theoretically emerge in Canada with climate change?
Well, it depends what you mean exactly by emerge. And I think going back to what Steve just mentioned about, and there's a difference between short-term local transmission versus them being something that is endemic to Canada, like Lyme disease is now, and to think to a large extent West Nile virus, and at least in some locations. But I think that some time ago, when we first started thinking about the impact of climate change on vector-borne diseases, we were kind of way down at the bottom end of the possibilities was the exotic vector-borne diseases like Zika virus and chikungunya and dengue and so on. We're probably having to change our minds a little bit about that because for two main reasons. I think the first is that Canada is warming faster than pretty much anywhere else in the world, and it is warming in general. The climate is changing faster than the models have projected, so things are happening pretty quick. And then we find that actually the Asian tiger mosquito, Aedes albopictus, has set up home in some warmer parts of Ontario, not quite into Toronto as far as I'm aware, but then this is a relatively early stage of the warming of Canada that's going to happen inevitably over the coming century, whether we stop producing CO2 tomorrow or not, because CO2 lingers in the atmosphere. And so yes, we now have to take seriously the idea we might get somebody coming back from vacation, viremic with Zika virus or chikungunya, and that there may be local transmission during the warmest months of the year in Canada, when the temperature's warm enough for the actual development of the virus in the mosquito, when a mosquito bites that viremic person. And then, as Steve said, there's this kind of link about not only the possibility of transmission here, but also what's happening elsewhere in the world has an impact on how many people are coming back viremic. So these are all questions that we are exploring in the work that we're doing to try and identify, well, what is the risk and where is that risk occurring?
Perfect. Well, it's a lot of great little pieces of information there. When you mentioned the Canada's warming faster than the models predict, it reminds me of those doomsday sci-fi movies like The Day After Tomorrow in 2012, where it always happens faster than when they predict. And your discussion about patients being viremic, that of course lends itself to anthrocogenic transmission if the mosquito that's able to accept the disease back from the human can then harbor that and transmit it to another human being who perhaps didn't travel. And that's a great segue into our travel segment of our discussion. And you also mentioned risk. So I think there's no better individual to present some slides on risk than Dr. Stephen Schofield. So Dr. Schofield, over to you.
We'll see about that. And I'm just going to focus on dengue a little bit. And really the intent here is, one, I like walking upstairs. I like swimming against the current a little bit because sometimes it forces you to re-examine preconceived notions. And I think that's a good thing. I think the other thing this is intended to highlight, and it might not be the same for everything, is this really context dependent It's really beast dependent, both mosquito, both pathogen of interest. In this particular case, we're just going to speak to dengue right now. And mostly in the back of my mind, I'm thinking, how concerned should we be from a population or public health perspective? And I'm going to try to convince you that maybe not all that concerned when benchmarked against other things that climate change might impact. So to summarize my perspective, it's that climate change absolutely scares the poop out of me, for myself, for my boys, and of course, should they decide to have children, for their children. Dengue in Toronto, not so much anytime soon. Do I think it could occur? I would even go further than Nick. I think it's a matter of when, not if, but I don't think we're looking at large outbreaks anytime soon. So next slide, please. Next slide, just click it again and again. So a little bit about dengue. A little bit about dengue in France. I'm using some of the headlines that you highlighted at it, including from Oliver Brady, who I think was actually amplifying inappropriately the potential threat in France in his article. And I think it's a good thing to evaluate that. The bottom line is dengue has been occurring in France for some time because Aedes albopictus, irrespective of climate change, made its way into France. How did it make its way into France? Well, we shipped it there in shipping containers, etc. So it became established. So it was a situation waiting to happen. You have virulent people coming back, you get some dengue transmission locally. So going back to 2022, when the article, or when he highlighted the increased burden of dengue in France, it is absolutely the case, as highlighted by ECDC, that there was various small clusters of dengue in France. This year, the bottom in 2023, as of the beginning of October, which is pretty close to the end of the potential dengue season in Europe, about 74 autochthonous cases of dengue in France, in Italy, one in Spain, almost certainly all associated with Aedes albopictus, which actually isn't a super good dengue vector compared to, as we'll find out momentarily, another mosquito called Aedes aegypti. Tiger mosquito, Nick already made the point, that is Aedes albopictus, the one that isn't so good at transmitting dengue. So let's have that in the back of our minds when we're thinking about this. Now, a little bit about dengue from the WHO. In tropical areas, it's a problem. Up to 400 million infections a year. Probably 50 to 100 million symptomatic cases. So the majority of infections are asymptomatic. Of those symptomatic cases, perhaps 500 cases of severe disease. So the ratio of symptomatic to severe is quite low. And even lower still is the ratio of severe disease to death, probably about 20,000 deaths a year. In all likelihood, or a rough estimate, about 1 death per 20,000 infections. Now, a little bit about the genetics of dengue. There's 4 serotypes. And I think this is important, again, in thinking about the impact in Toronto. 4 serotypes. They're different. They elicit different immune responses. Bad dengue, that is severe dengue, or worst case scenario, fatal dengue, is typically associated with a second infection. So what happens is that a person's infected once, might not even notice they're infected, might be a little bit sick with one serotype. Let's call it serotype 1. They have a second infection, say a couple of years later, with a different serotype. And for a number of reasons, the likelihood that that's a severe infection or an infection that leads to death is higher. So it's the second infection with a different serotype that we're particularly concerned about. It's also important in terms of if we talk about vaccination. The reality is, if we get transmission in Toronto, even a couple of thousand events, they're all going to be, or most of them will be, primary infections. So that severe disease is less likely. So that's the landscape in terms of dengue. In terms of infections, there's a lot of them. In terms of the likelihood of severe disease, it's a different matter altogether. Important, absolutely, in endemic areas. Next slide, please. And let's just examine a few of the players. Mostly we're talking about the side of the slide where we have the mosquitoes on it. The big mosquito is Aedes aegypti. This is the mosquito that is particularly efficient at transmitting dengue. It's the mosquito that is found in almost all of those areas where we have the 400 million infections that is almost always suggested to be the most important vector. The little mosquito underneath it is Aedes albopictus. It kind of looks like aegypti, but it's different. It's not as efficient at transmitting dengue, but it is a little bit better at surviving in cooler climates. Upshot, when we've had those little bursts, those little clusters of dengue transmission, in Europe has been albopictus. It's not particularly good at transmitting dengue compared to Egypti, which is very good. Sidebar, why is Egypti so good? It specializes on humans. Not only does it specialize in feeding on us, which means lots of opportunities to pick up the virus and transmit the virus, it's pernicious. So it bites multiple times between laying batch of eggs sometimes. So there's lots of opportunity for transmitting the virus. That's one of the reasons it's so good. And an even bigger sidebar, but perhaps of relevance to pharmacists, for example, is it tends to bite during the day inside. So if you're a pharmacist and you're telling someone to use repellents in Canada, when do you tell them to use repellents in Canada? When they go outside. If you're going to a dengue endemic area, well, you might just want to consider wearing repellents if you can't exclude mosquitoes from your living area while you're inside, something we would never do in Canada. So that's a little bit different. Next slide, please. So that's sort of the dengue story a little bit. So it's a tale of two mosquitoes to an extent, I think, in addition to several other things, including the way we live, when we're thinking about emergence in Canada. I'm probably going to call this wrong, but I'm going to call these ecological niche models / maps. The one on the right, actually, Nick was involved with. Just because it's a little bit easier to interpret, I'm going to use the one on the left from the US CDC. Essentially, what we're looking at on the top in the blue is Aedes aegypti. On the bottom in the green is Aedes albopictus. And they're saying, oh, what's the suitability of the environment in those areas for having populations of either aegypti in blue or albopictus in green? Darker color means more likely. And the important point here is that if anybody pushes north, it's going to be Aedes albopictus in all likelihood. It's not a certitude, but in all likelihood. And that's the poor transmitter of dengue. So that's something that I don't want to say we can find comfort with, but it probably attenuates the impact of any transmission in Toronto if you don't have as good a transmitter. Next slide, please. Now I want to move to North America for a second, because we have we have autochthonous transmission of dengue in North America, in the United States, in the southern United States. Next slide, please. Mostly, and this is over about a 12-year period, mostly in Texas, mostly in Florida, tens, sometimes up to hundreds of cases annually. Next slide, please. If we focus in a little bit more, we find that the transmission in particular is highest in the Miami-Dade area of Florida and in several locations that are essentially subtropical in Texas. And I'm going to show a slide about this in a minute, but I'm going to give it away right now. Do you know who happens to live in those areas? Aedes aegypti. Aedes aegypti is the most efficient vector of dengue, and we're still not seeing massive burdens of disease despite the tropical context. Really intriguingly, if we take the Texas example, for example, Brownsville, they've done some serologic work in that area. On the US side, think screening, think air conditioning. On the Mexican side, perhaps not as prevalent in terms of comforts of home. The seroprevalence for dengue is much lower on the American side. So these physical barriers, your lifestyle can have a major impact in terms of exposure to vectors. And just imagine, again, the Toronto scenario, if it did really get warm and we had protected energy infrastructure, where would we be? We'd be inside in air conditioning. So the exposure context would be different. It would probably be lower. Next slide, please. And just remind that in Miami and in Brownsville, we're talking Aedes aegypti. So the efficient dengue transmitter, not albopictus, which is less efficient, but is the one that we think probably, if it happens, becomes established in Toronto. Next slide, please. And so just to remind, and Nick knows so much more than I do about these kinds of things in terms of forecast of climate. But on the top, we have Miami, and we have Brownsville. On the bottom, we have Toronto. Toronto ain't going to be either of these places anytime soon. And these are the places where we see Aedes aegypti. Next slide, please. So do I believe we may see dengue in Toronto? Absolutely. Do I think we should be aware of it? Absolutely. Am I particularly concerned about it in the panoply of other things that climate change can impact? Not particularly. Case in point, Brady was getting all worked up about dengue in France in 2022. There were 60,000 or more climate heat-related deaths in Europe that same year. no deaths from dengue. Indeed, the overall burden of dengue-related mortality in the world that year was about 20,000. So my point is there's bigger fish to fry. Next slide, please. I just think this is a good quote, because you're like, it shouldn't intimidate anybody, but it's like, really it's about prioritization. The state of the climate report. We warn a potential collapse of natural and socioeconomic systems in such a world where we will face unbearable heat, frequent extreme weather events, food and freshwater shortages, rising seas, more emerging diseases, and increased social unrest and geopolitical conflict. Dengue in Toronto, against this full backdrop, probably isn't a super big deal. Next slide, please. And next slide. So my conclusion is essentially, climate change is a big deal. Dengue in Toronto probably ain't, at least anytime soon.
Great. Well, thank you so much for that excellent presentation, Dr. Schofield. Dr. Ogden, any comments? I think some of your research was showcased, so I thought I'd allow you to have
that's work done by Salah Khan under the supervision mostly of Vicky Ing in our team in a previous time when we weren't focused entirely on COVID. But going back to that a little bit more now. I concur with Steve about dengue. Is it something that terrifies me? No. Is it something that worries me? Yes, and it does, particularly because of the other mosquito-borne diseases, the Zika and chikungunya, perhaps, which are as a more likely, well, particularly chikungunya, more likely to actually produce symptoms and end up with people who have got long-term problems subsequently. So I think knowing about it is important, and looking out for it is important, and having a kind of guidebook as to what to do when it happens. Amongst some of the challenges there are the idea that, and I think there was the example of the first chikungunya outbreak in Italy, which I think was 2007, and there was no expectation that dengue would ever be transmitted there. There was a question in the chat about, can these mosquitoes change to become more adaptable or to be able to transmit the viruses at lower temperatures? And indeed, I think that's what happened, is that Aedes albopictus had undergone a genetic change which allowed the transmission to occur in Italy. But to my point, that it took quite some time before they realized that outbreak was happening, because it was happening in people who'd never traveled out into a place where dengue would be expected, and where if they went to a doctor feeling ill, the doctor would in any way suspect that they may have one of these illnesses, which of course delays diagnosis and treatment in the individual and delays our capacity to actually control outbreaks. In other words, the outbreak's well underway before anybody's got an idea about how to control it. So I think we have to think about it pretty hard, and I think there are some questions later about what do we do about this, to which I'll have some answers.
Nick, and I think it would be worth even raising the point that you made earlier. Being aware of what's occurring outside of Canada is hugely important in terms of forecasting this kind of thing. And I think that chikungunya situation in Italy is an excellent example, wherein there was a massive outbreak in the rest of the world. So, as you mentioned, Nick, the burden of travelers infected with chick coming back to these areas, we didn't know necessarily about albopictus at that time, but maybe we should have thought more carefully about what the implications of that changing dynamic of chikungunya and transmission outside of Italy, outside of Canada, would have in terms of importation of those cases into Italy or into Canada. And a right now example, and I agree about chikungunya, by the way, it worries me more, is there's some really nice CDC data. There was a explosive outbreak of chikungunya in Paraguay just over the last year. And chikungunya is a funny thing because it just explodes in 3 or 4 months, and it might be gone in a year or so. But it affects a lot of people, and 20% of them can have permanent sequelae that last, months to years. And the number of travelers from the US going to Paraguay was like less than 1% of the entire US travel population expected. But the number of chikungunya cases coming back to the US, I think, exceeded 30%, more than 30% of them were going to that outbreak to Paraguay. So it just highlights how much so the relative risk for having chikungunya when they returned was more than 30-fold if you went to Paraguay. So it just highlights how those kind of situations can really impact what's coming into your country.
I concur. And there's been, we now have a pretty solid process for identifying threats that are occurring in Canada, but also abroad. And that amongst the first thing for those happening abroad is that we use importation models to assess, well, how many cases might be coming in and where will they be landing. So that's part of the risk assessment process.
Great discussion. And sorry, I didn't remind others attendees, feel free to post your questions into the chat. Thank you, Dr. Ogden, for being so astute in identifying that. There is a question about preparing our public health system to better address these emerging threats, especially preparing our public health workforce and clinicians as they don't notice these kind of clinical cases. And I think you brought that up, Dr. Ogden, is that if it's not in your radar as a differential diagnosis, it could lead to delay in treatment, especially if the person acquired it locally. It just wouldn't cross someone's mind, and there could be some sequelae. But we will address that in our strategy section. So we will park that and actually switch gears now from mosquito vectors to tick vectors. And of course, Lyme disease, Dr. Ogden, you mentioned that. Let's turn it back to you, Dr. Ogden. What have we seen with Lyme disease in Canada?
Well, when I first arrived in Canada, I think there were 2 locations where the black-legged tick was known to exist, and they think now that maybe they were refugial populations that had survived there during the Ice Age. And I was undertook a modeling study to explore what potentially might be the kind of climatic limits for this tick, and if could climate explain its limited distribution in Canada, and if so, well, what will climate change do? If we've got some climate models to say, well, how much warmer climate Canada will become, will that allow the tick to come in? And the answer was yes. Probably the climate limit that we worked out could actually explain its limited distribution, and if it does warm as projected, then it could move in. We had a number of surveillance efforts that were going on. My colleague Robin Lindsay, who's sadly now retired from the agency, had set up a passive surveillance program in the 1990s and early 1990s, and it lasted for about 20-something years, which meant we had a long data set. And I mentioned this, just alluded to it when I was talking about malaria, is that being able to detect and attribute changes in patterns of vector-borne diseases really means that you can only do it when you've got long data sets and so we undertook a lot of field surveillance to kind of validate what our models were saying. And that really underpinned the idea that the geographic pattern, both at a local and a national scale, was consistent with what the models were saying, and particularly the kind of the limit, the kind of temperature limit for the survival of the tick populations, which, as it happens, is not how cold it is in winter, it's how warm it is or cool it is in spring, summer, and autumn, which determines how long the life cycle is. Because in the winter, they huddle down in the duff layer in woods and survive perfectly well. It's -3 or 4, even when it's -40 above, and they survive perfectly well. So what allows the populations to survive is the warming during the spring, summer, and autumn, shortening the life cycle. So we have been able to see and track the emergence of the tick, the geographic spread of the tick year on year into southeastern Canada, from Manitoba eastwards, and then the emergence of Lyme disease as transmission cycles of Borrelia burgdorferi have emerged, and that emergence just continues to this day, as we see year on year the numbers of reported cases increasing and increasing. We have seen that is increases due possibly to some extent increased awareness, but pretty much it's the ecology of the tick, what's happening out there, that is driving that increased hazard to the public in the environment. And that is the range of the tick is spreading northwards, so more areas, more people exposed. And behind that advancing kind of northern edge of distribution, we see the more and more of the possible habitats actually becoming filled with ticks, and the density of ticks, the abundance of ticks, how many you can encounter per unit area, per unit time, increasing year on year on year. And at the same time, those Borrelia burgdorferi transmission cycles getting going better and better and better as more ticks are there. And the proportion of the ticks that are infected is increasing as well. So that's all happening right now in Canada, and as well, we're now seeing a whole load of other tick-borne pathogens that are transmitted by the black-legged tick, including Anaplasma phagocytophilum, Babesia microti, and a number of other bugs as well. So we're definitely seeing that and living it. And courtesy of the combined spatial pattern of spread, which is pretty solidly indicating that temperature is a really strong determinant of the geographic pattern of spread, combined with the timing of emergence of the populations elucidated from Robin Lindsay's long-term passive surveillance system that he established. Now, I say it's not just him, it's with provincial partners as well. But nonetheless, that allows us to identify that the populations didn't take off until Canada started to become climatically suitable. And the timing of that was when the warming of Canada, which there's been warming and cooling and warming and cooling over millennia, but what we saw is that it, just as the temperature started to increase outside of that normal pattern, is when we started to see the emergence of the tick populations in Canada. So some reasonably strong attribution of the emergence of the tick and Lyme disease to climate change.
That's great. Thank you, Dr. Ogden. That's a very comprehensive overview, and it seems like we are living this at this moment. And I think there's no better person to comment on that than Tracy, as a avid outdoors person, as well as somebody on the front lines who's seeing patients present with Lyme disease and now treating it because of the expanded scope of pharmacists in Ontario for such a condition since January. So I guess moving to Tracy, what has your experience been, and how have pharmacists been supporting patients having access to care because of this incidence? Are you seeing more incidents? Would love to hear your experience.
Sure, thank you. And I think Dr. Ogden is exactly right. Like even on a micro level, what we see here, even year in and year out, you even have a small, temperature blip, like that nice week of patio season in March that you weren't expecting. And all of a sudden we've got lots more tick bites and activity in all of our areas. We're located right next to a conservation area. So we have a lot of people that are enjoying the outdoors there, myself included. And he's exactly right. Like where you used to walk through and pick up a few ticks, maybe now you'll walk even in the short grass and be just covered in really active ticks. I find sometimes too now what's a little bit different than previous is that, it used to be once upon a time, you knew you had a tick bite. You had to remove it. It was there. You had some idea that you had this issue. Unfortunately, in the last few years, there seems to be a lot more, I'm not sure how you want to term it, but where people just have no idea, and you have that segment of the population that doesn't develop a bullseye to a tick bite, and so they'll all of a sudden have these symptoms of Lyme without ever having knowledge that they'd had any kind of bite. And so they may have been in our area, gone back to where they're from, and again, just as was described earlier, their physician sort of has no clue where they may have picked up any kind of tick-borne illness. But from the certainly because it's a timely issue as well, the time to treat is really important. Then pharmacists having that as their part of their scope of practice in their prescribing certainly is important. It's one of the things in Ontario. I was on our regulatory college board at the time when this came before us from government. And it wasn't part of the initial minor ailments that were suggested. But myself and a colleague who operates in the Ottawa area knew this, of course, was, one of the things where pharmacists could really make an impact. The whole purpose for pharmacist prescribing is to really allow that expansion of our scope to really increase capacity in the healthcare system, to really allow our resources, which, already strained before the pandemic. I think we, can agree that they are nothing like they used to be before. Everyone needs to do what they can in order to allow those resources to be properly allocated. In a rural area like ours, we don't have acute care. There's no walk-in clinics. Our family health team does have after hours care, but that's, not all the time, and they can't see everyone. And certainly being a vacation area, we have lots of travelers that are here and people visiting family. And so their only avenue in this case is to head to emergency. And certainly that is not really the most appropriate place for this kind of an assessment. So it's a welcome addition to our scope. I'm very happy that the Ontario government agreed to add that. I can tell you some days I'm doing like a couple of dozen assessments for this. You can always tell on the days when it's nice out. Tomorrow, I'm going to see a lot of people with tick bites. Today it's snowing actually where I am. So it probably will be a little quieter tomorrow. There won't be as many people outside, picking up their tick bites. But a fun fact of rural living is Monday was the opening of hunting season. And so, if you're at all into that, you've got lots of gentlemen out in the bush. And some years we joke in the pharmacy, but there's so many cases of tick bites that sort of need assessment and treatment. We've got the doxy out in little Dixie cups across the counter, and people are just coming in and getting their dose and heading back out to hunt, which anyway, is probably a whole different conversation. But certainly having us be able to do that is really great. Especially too, I mean, pharmacists are often, we're open, longer hours, evenings, weekends, again, we're there. So we have the access for the public, which they're really enjoying, certainly being able to do that and take advantage of that rather than other avenues to seek care. Now what we're finding in my area specifically, I know in the ER, someone will present with a tick bite that they and a tick that they need to have removed. In triage, they'll remove the tick and then they'll send them to me for the assessment. And so again, freeing up capacity in our ER for more serious cases. But it's all also about collaboration. We work really closely with our family health team. It's really important to be reading from the same book. Like, we use all of public health guidelines, as does our medical clinic. We make sure to, touch base with them on a regular basis, see what new information they're using, what information we are getting, making sure that we're in sync. Even for vaccination, which I know we'll talk about a little bit later. One of the members of our family health team is on public health vaccination working group. And so, she provides us with regular updates on what's going on so that we're aware and can be, again, doing all the same things so that patients are getting the same level of care, and that we are also, providing the same level of care no matter where the patient goes. And so there's also that level, I think, of comfort and familiarity when we're all doing the same thing, so that if they see an assessment that I've done, they know that it's the same kind of assessment they would have done, and vice versa in any other kind of area. So it's been actually really interesting. I was just I have to have some data of my own. You guys have all the data. But it only just started in January. And I think we have to recognize that Ontario, this is great, but Ontario is a little bit behind in prescribing. BC as well, who's also just recently enabled pharmacist prescribing. Some other provinces like Saskatchewan, Alberta, New Brunswick have been prescribing for nearly 2 decades. So, we're a little bit behind, but at least we're getting there. I guess you have to agree that better late than never, for sure. So we're happy to have it. We started in January. We've done almost 1,000. We've done 944 to be very specific assessments since January, and over 300 and a quarter of them, are almost 35%, are tick assessments that we've done. And I mean, certainly, people are aware, a little bit more aware. There's a lot of fear, I want to say, around Lyme disease. Of course, people are reading lots of information about untreated Lyme disease. And again, what Nick was saying is completely true, right? Like if you have, people that don't remember they've had a bite, and they don't really pay much attention to it. They sometimes can have a little bit less severe disease at first. They don't really treat it. They think it's something else. It kind of goes away. And then it emerges later with a lot more serious disease that they then have a little bit more difficulty, or someone has a lot more difficulty diagnosing and then treating. So, this is something that we still see quite a number of people. We don't treat everybody. Obviously, there's about 25% of people that we see are not really needing treatment. And so it's really just educating them on how to protect themselves, what to look for, how to monitor themselves, and how to protect themselves in future where we are. So I think, I think it's been quite a positive change for Ontarians and anywhere else where this is within pharmacist scope of practice.
That's great. Really fantastic example of how you can immediately implement and thrive with a scope of practice and the benefits of the patient community. Long overdue for sure. I think even when Nick was saying we need long data sets to understand epidemiological changes, we need long durations of pharmacists expanded scope. I think, I'm from British Columbia. We just started in the summer, so 6 months after you, and we're seeing lots of great embracing it. Like you said, you're always staying up to date, you're communicating, you've got that relationship, taking the strain off the ER. I really hope that these regulations can stop. I often think they're slower than climate change. No pun intended, but definitely intended there. And it's really great. This is definitely a solution to help address some of these challenges in patients accessing healthcare. So thank you so much for that, Tracy. Before I move to the travel medicine side, I just wanted to show this picture here. This actually led to quite a heated debate. I exaggerate that between us panelists. So to clarify, these are dogs, and actually to the left is Dr. Schofield's dogs, and to the right is Tracy's dogs. And dogs are not vectors. The tick is still the vector. So there, Dr. Ogden, I'll make sure to say that. But they do play a role in this
I'll step in afterwards,
this whole
just
pattern.
afterwards.
So, Dr. Ogden, did you want to?
Oh, well, I was going to say that indeed, dogs can't transmit Lyme disease to you. They can get Lyme disease, but will not then go and kind of transmit it to you. However, they can be a source of ticks for people. In other words, dogs are fantastic at picking up ticks when you go out for a walk in the woods, and they can bring in ticks. The ticks take a bit choosy about where they're going to decide to feed, because obviously they want to find a place where they're not going to be scratched off so easy. And so they take a while wandering around on the fur before they start to feed. If the dogs come in with the ticks which are not attached, then they can fall off and be in your house, and then they can come and get on a person having acquired the tick in the house. So hence, amongst the recommendations we make is the idea that treating your dogs appropriately for ticks with tick repellents is as much important as treating yourself with insect repellents that also work for against ticks. And one of the issues people do often talk about, there's been a bit of a past literature that has used the word vector to mean the animal hosts of infectious diseases, when that's probably not the right way to look at them. That those animals are the reservoirs of those bugs. But some bugs, well, yeah, maybe you could actually acquire the infection directly from the animal, but those are not what I call vector-borne diseases.
And I was just going to add something from a One Health perspective, Nick, and maybe the pharmacists already do this, but if you have a person, we'll use a hunter as an example, coming to you, it's quite often they work with dogs. It might be an opportunity to discuss with the individual that there are options for reducing tick burden on their dogs, whether it be topical repellents or insecticides, as Nick describes, and or systemic treatments that work very well on ticks that start to feed. It kills them very quickly. Now, the second one wouldn't necessarily preclude a tick jumping on a dog's head and then jumping on you, but there is a One Health aspect wherein people can protect their dogs and protect themselves, and people are pretty attached to their dogs. So maybe it's an opportunity, a point of leverage for encouraging people to do things to protect themselves against tick bites.
Yeah. And I think on top of that, I think, oftentimes we're seeing that, the ticks are not necessarily biting the dogs. They are using them as the transport mechanism. They're sort of on them, as you've indicated. My dogs are all vaccinated, treated, but they'll get 30, 50 ticks on them in a morning walk, quite a lot, but none of them will bite them. And so, the medication that you're using to treat them is excreted in the skin. And that's how it works, right? When they bite. But I'm not sure if, maybe some kind of evolution, who knows, that, that they're sensing this. There's not as many, I'm not seeing anyway. And again, it's anecdotal, not seeing as many bites, but seeing them, on them and then being entered into the home. And oftentimes we're seeing a lot of people that are getting their tick bites from, at night when they're sleeping, from a pet that sleeps on the bed. So everything that you guys have said is absolutely true. They need to be treated, but we're also doing a lot of information with people around, making sure that you are physically monitoring them, wiping them down after you've taken them out, despite all the other treatments that you do. Because yes, Lyme, of course, in animals is very serious as well. But yeah, but just minimize. It's just another step in minimizing people's risk and exposure.
Actually, it's just that there's a question here that I think Nick is probably the best person in the world to answer in the chat, and it's to what extent do we know the effects that land use change, for example, clear cutting, is adding to tick habitat expansion, particularly in certain geographic regions? Is this included in ecological niche models?
So there's a number of answers to that question. Generally, there is it's considered that the key hosts involved in maintenance of the tick, particularly white-tailed deer, are their abundance is helped by the amount of what's called ecotone. So wood edge is a better place for deer populations because there's a lot more kind of diversity of food sources and so on there than actually a kind of like mature woodland. So there is an impact of kind of how the landscape is constructed. And we can actually use that in these developing, risk models and understanding that, because you can actually calculate in using geographic information systems in a particular area, well, how much of that is, how much is solid woodland and how much is ecotone. And if you've got more ecotone, depending on circumstance, you may end up with more risk. The idea of clear cutting as such, in other words, going from kind of 100% wood to 100% not wood, is something that in a short period of time could end up with a transient increase in tick, because you've got nothing to stop maybe people get a bit more likelihood of contact with ticks in that environment. I'm being a bit kind of woolly about that because I'm not quite sure. One thing that's certain, and I'll come back to the reason why I say that, one of the things that would be certain is that once you take away the wood, that environment becomes a place that is very inhospitable for the tick. The woodlands provide two main things. One is, as I mentioned, that duff layer that protects them from freezing in the winter, and it provides the duff layer that protects them from drying out during dry periods in the summer. And if you take away the woodland, you will take away that, and the ticks will die. And if you take away the woodland, you pretty much take away most of the hosts that the animal hosts that ticks live on, and that will actually stop the ticks from surviving in that area. There is a little caveat about that, and it was in some studies colleagues did in Maine, where they decided they had some islands or an island where they could go in and cull the deer population and see what happens to the ticks. The theory being that you can't have ticks without this particular species of tick, the black-legged tick, without deer. So they culled the deer off the island, and indeed, after over several years, because the life cycle of the tick is 7 years long, then the ticks were no longer present. So it did actually kill the ticks, but for a short period, it actually increased the number of ticks in the environment because the deer were no longer picking them up and feeding them. So if you take away the hosts transiently, then you'll end up with more risk transiently.
Very interesting. So that wraps up our section on Lyme disease. We'll quickly do a brief primer on international travel. I think a lot of this was discussed already. Myself and Dr. Schofield have different perspectives, one from more military, one from more civilian. And I think that also comes down to people who have to pay for this service, because as civilians, traveling abroad, it is considered a luxury. So all anything besides routine immunization updates, vaccinations for Japanese encephalitis, rabies, as a preventative measure are typically pay out of pocket. And unfortunately, when we look at the data, we don't see so we see a lot of Canadians traveling, but we don't see a lot of people seeking pre-travel advice, even though it's recommended by the government of Canada. And of particular risk are those, we call them VFRs, so visiting family and relatives. So they often are born in a country, a developing region, come to Canada, settle, and then go back to visit friends and family. And often they take longer itineraries. They're a bit more immersed in adventurous eating and things like that. So they're at disproportionate risk for contracting, among things, food and water and vector-borne illnesses. We did address this question: does a vector-borne illness contracted abroad affect our population at home? And Dr. Ogden mentioned it. It was that viremia, if they do contract it, and they're sufficiently viremic, they can potentially send that back to a propagating vector host here and potentially lead to a endemic transmission cycle. But as Dr. Schofield and Dr. Ogden said, that's extremely low likelihood. But at the end of the day, we should definitely be advising travelers to, if they're going to endemic areas, especially for chikungunya, as mentioned by Dr. Schofield and Dr. Ogden, high chance of symptomatic infection and potentially long-term sequelae, especially with debilitating joint pain, which is a phenotype of chikungunya. And unfortunately, globally, we are seeing an increased spike, as Dr. Ogden mentioned. Hard to tie to climate change, but it is definitely happening. So the mosquito vectors that transmit this illness are certainly propagating in different regions. So I wanted to kind of, before we go to our strategy section, because we're coming to the back third of our panel discussion, seems to have gone by so quickly, is there's a couple of vaccination candidates in the pipeline for these vector-borne illnesses. So some are more on the horizon than others. So this is the single live attenuated shot against chikungunya, manufacturer's Valneva. It's been submitted to Health Canada for a new drug submission for review, and pending on what Health Canada decides, it would be mid-2024. Takeda's Qdenga has been approved in other parts of the world. So in Europe, for example, it is being used. To Dr. Schofield's point about the different serotypes of dengue, the Dengvaxia candidate from Sanofi Pasteur, unfortunately, if you vaccinate against one serogroup, you can get that enhanced disease if you're subsequently infected by another serogroup, because it can pick up some of those antibody pieces and enhance entry into the cell, antibody-mediated enhancement. Where this vaccine did things differently, it's the backbone for all four, and it's designed to protect against any of these serotypes. So certainly an upgrade on Dengvaxia. For Lyme disease, we are a bit further away. There is a Lyme disease candidate. It's a coalition between Valneva and Pfizer, and this vaccine is currently in clinical development. So currently, when we look at these vector-borne illnesses, what we have now is vector control methods, repellents. I think some great advice from Dr. Schofield mentioning perhaps even education patients indoors, especially if they're in developing countries with Aedes aegypti aggressively biting indoors. Reapplying repellents is never a bad thing, especially going in and out of the water, but perhaps just like sunscreen, people are under applying. But how are we kind of potentially looking at the use of these three vaccination candidates for our patient population locally and abroad? So I'll turn it over to the panel. I guess I'll start with you, Dr. Schofield, because you practice in travel medicine. You're plugged into some of these advisory committees. What's the general consensus?
I think that's a good question. I'd add another one to that list: tick-borne encephalitis vaccine that was recently, last year, approved by ACIP in the US, was licensed in Canada up to about 10 years ago. Tick-borne encephalitis occurs in Europe, particularly in Eastern Europe. And of course, there's more and more activities in Eastern Europe. So it's a vaccine of interest as well. Do you have, I think you have a list of the vaccines. Maybe you could flash them out there. It might be the next slide. Maybe I'm just making this stuff up.
No, I don't have a list, but I have the chikungunya, the dengue, and the Lyme.
So should I go through the vaccines one at a time in terms, and this is just my opinion right now in terms of what's going on in the world and how we should think about them. So let's start with chikungunya vaccine. It's a live attenuated vaccine, single dose. Right now, the evidence suggests, and it's a surrogate of protection. It's not efficacy in terms of disease protection, in terms of the outcome they've been able to look at to date, because it's really hard to test this in a natural setting because chikungunya outbreaks are so fast. By the time you've got the vaccine in the arms, the outbreak might be over. So they're using a serologic endpoint. And it looks pretty good. Single dose live attenuated vaccine, well, more than pretty good. It elicits an immune response in almost all the recipients. They have an age range right now. I think the indication in the US is for, and it's not licensed in the US, but the proposed indication is for age 18 and over, including those over age 65. To date, the safety profile looks good. And here's where it gets tricky. So who might you recommend the vaccine for? Like, it's a non-starter right now for Canada in Canada. So we're thinking about travelers in a specific context. We know that chikungunya has explosive outbreaks. So if you know an individual is going to an outbreak situation where attack rates can be high, and we know there's a high probability of sequela, then I think, I'm not going to say it's a no-brainer, but that certainly would be a population for which you would seriously entertain providing chikungunya vaccine or encouraging use of chikungunya vaccine should it be available. The challenging situations, and the ones that I think the advisory panels will wrestle with, is the situation where it's not an active outbreak. And that represents the large majority of the world at any one time. Low levels of chikungunya transmission, risk to the traveler, very low. Cost of the vaccine may be somewhat substantial. And so when would you recommend the vaccine, or would you recommend the vaccine for travelers going to areas where chick might occur, but at that time, there is an intense transmission? So is it a reasonable travel vaccine? Yes. How will it play out for travelers and who should receive it is, I think, the uncertainty. That would be my response to chikungunya. You want me to carry on, or should I pass dengue over to somebody else?
No, carry on. Yeah.
So dengue, I actually have to, I don't think that the Takeda vaccine is necessarily a perfect vaccine. There's some uncertainty there that is concerning. And it's concerning because it's uncertain. I'm not saying this is a safety issue, but it is not clear yet that there isn't this immune enhancement associated with a vaccination followed by a primary infection for dengue 3 and dengue 4. I think we want more data before we see that. So the Takeda vaccine, there was an application made in the US. It was withdrawn from the company. I don't know why. It's been approved by the EMA, the European Medicine Authorities. However, I do know some of the major regulators are still struggling with how to make recommendations for travelers, if they're going to make recommendations for travelers in the European setting. For example, those in the UK, those in Germany. So I think what that vaccine means for travelers remains uncertain. I think it's something that would be hard to make recommendations for travelers because we presume the large majority are naive. We know the risk of dengue is pretty low in travelers, particularly for severe disease. So we're starting out with a low baseline risk. So the acceptability of any adverse effects that might be severe is pretty low as well. So I think we need more time to think about the Takeda vaccine. There are other vaccines like TV003 that might be coming to market that look to elicit viremia, because these are live attenuated vaccines, viremia to all 4 serotypes of dengue, and they might actually be more attractive. As I recall, TV003 is also a single shot vaccine, so that would be really cool, particularly if we can get around this issue of concern around the uncertainty of could it potentiate dengue. I think the Lyme vaccine is super cool, and Nick probably knows more about this than I do. Why is it super cool? Because they're immunizing us to make antibodies that when the tick starts feeding, the antibodies go into the tick and attack the Borrelia in the tick. So you're actually attacking the pathogen in the tick, not in you. Super cool technology. Time will tell in terms of its utility. I mean, I think it's encouraging. I think one of the, it's not a concern, it just might be a real life scenario, is that you might have to maintain pretty high antibody titers in humans, because you need to get enough into the tick to deal with Borrelia and the tick. And I say that only because it might mean that there's a recurrent need for boosters for the vaccine. I don't know, but that's one possibility, which might limit, depending on acceptability, safety, cost, and other things, the applicability or usability in certain scenarios for the population. But I think it's really interesting, and I'm excited to see what happens. So that's my thinking on those 3 vaccines.
Great, fantastic overview. Dr. Ogden, did you have anything to add about the Lyme disease vaccine candidate?
Yeah, I mean, I would be extremely happy to see an effective vaccine out there. I mean, we have to bear in mind that in the US, there are about 40,000+ cases reported a year, and that, or 35,000 cases reported a year, and that is based on the estimates of US CDC, that probably less than 1 in 10 cases are actually reported in their surveillance system. So we're talking in the order of 500,000 cases of Lyme disease a year. And that is with all our efforts to try and prevent it. Our toolbox for this disease that is emerging in Canada is not great. And to have an effective vaccine would be fabulous. I have a little, I'd like to see some effectiveness data. However, well, as I agree with Steve, it's a great idea that that to produce antibodies against the bugs in the tick, because the bacteria are in the gut of the tick. Once the tick starts to feed, then they start to multiply and then migrate through the body of the tick into the salivary glands, from where they're delivered into the person that the tick's feeding on. And that's one of the reasons why actually a really effective way of stopping or preventing Lyme disease is actually to give yourself a tick check when you come home and pull those ticks off before that has happened. So tick checks really work. But I'm a little, and I'm going to get a bit geeky here, because actually I think ticks are fabulous creatures and fascinating. They've co-evolved with, I mean, each stage of the tick is parasitic, and they've co-evolved with mammals and the mammalian immune system, which is trying to kill them for millennia. And because of that, they're pretty good at it. Their salivary glands, which in the flat state, I think it's about 1/3 of their body weight, produce an extraordinary cocktail of immunosuppressive and immunomodulatory bugs, which are there, immunomodulatory chemicals, which are there to stop the immune system of their animal host from killing them. But that's where the bugs are being delivered, and that's the environment in which the antibodies are occurring that we're hoping that the ticks will ingest. So I still am concerned that the amazing co-evolution of ticks with the mammalian immune system might somehow impede the effectiveness of the vaccine. But I'll be very happy if it's effective.
Great. One last thing, of course, for you, Tracy, is given there's excellent data with this Lyme vaccine, and it's approved, and there's a recommendation. Unfortunately, the way things are set up in Ontario with vaccine scheduling, you won't be able to actually administer this without a medical directive. Is that correct? Because in BC, all vaccines are Schedule II. So as pharmacists, we can independently dispense and administer vaccinations as per any guideline. Alberta, obviously, Schedule I, Schedule II doesn't matter. They have prescribing authority. It's unfortunate that the regulations are really handcuffing you, so that actually, if the way it stays now, you will be able to treat someone for Lyme disease, but you won't actually be able to prevent it.
Well, you don't have much faith in me. I don't know. I never take no for an answer. Good Lord. You are correct. Ontario is hampered with a scheduling system that, just like RSV that's just come out, we still are not technically allowed to enable it. But, again, collaboration with the people that you work with, you can administer them through a medical directive. You can administer them even through a direct order, which is slightly different, but it's not a barrier. Despite vaccine fatigue, this would be a vaccine that would be, given it's effective, et cetera, all the parameters that we just discussed, would be something that would be very welcome in our area. Up until now, we've been sort of limited with Lyme, but over the last 2 years, we've now had several cases of anaplasmosis. And so, we're waiting to see the emergence of other more severe disease as well. But this certainly, almost more than anything else in my particular area, is very important to people. And so, I get questions about this actually quite often. Where are they in the stages of testing to have a Lyme vaccine? Why is it that my dog has a Lyme vaccine and I don't have one? These are the questions that people are posing, and I think they're very receptive to being vaccinated in this area. And again, lack of official authority, because we have these other tools available to us, is not a barrier and should really not stop any professionals from working together and making sure that patients get the best care.
That's great. No, I think that's what we need is to better advocate for expanded scope. It's better to say, like, we can do this versus we're doing this. So I think that's fantastic. I think, just given that we have less than 10 minutes left, maybe just each panelist can kind of summarize moving forward, how can we, what are the key takeaways in terms of addressing the health of Canadians against vector-borne diseases, both domestically or abroad, if you want to add that in there. So I guess I'll start with you, Tracy. What are the key takeaways here from this discussion?
Well, everybody has made me really afraid to go outside anymore. So I thank my fellow panelists for a lot of that really great information. But I think it just really highlights the role that we all play in education. I think for me, it's continuing to make people aware, to take the proper steps for their safety, to realize that, things are changing. I think the pandemic, one of the things, has made people a lot more, like the public, a lot more aware of what's going on around the world and how that can affect them, regardless of whether they traveled or not. I mean, the pandemic was a great example of that. So I think that, having those conversations, letting people know that there's other things that are coming that they really need to, be prepared for, and how to prepare, like how to take proper precautions, I think is, my message to other pharmacists, that don't let up, make sure that you are covering all those bases with patients, because it's not good enough to just continue to treat. We really need to prevent. So.
Perfect. Dr. Ogden.
So, sorry, which one of these am I answering? Any of them? All of them simultaneously?
Yeah.
I think that, we are doing our best to prepare Canada for the diseases. We're identifying, using modeling methods, where and when there's such as those that Steve identified, where and when the bugs and the disease, or the vectors and the disease they transmit, are likely to end up. So that's the first thing, is awareness for us nationally and also for locally, when and where we might end up having these disease problems, and then developing information on those, understand a lot of it from the literature and knowledge synthesis pieces, so that people know what to do, how to diagnose them, what the clinical pictures are, what the how to prevent, etc., etc. So there is some information ready to go in case these diseases emerge, and also developing methods like forecasting for West Nile virus and so on, which will, we hope, although it's a pretty complicated process, but hope will alert people to when the risk is where and when risk is really coming your way, so that people can be told, well, you may not be being very diligent about protecting yourself against mosquito bites and in general, but if you're going to do that, really do it now. So in which case you may get better uptake for that. But there are a number of other obviously methods that we can apply in enhancing our surveillance, enhancing communications to the public, and that's all part of our kind of like adaptation to impacts of climate change on infectious disease risks that we undertake at the agency.
Excellent. Dr. Schofield, final words of wisdom.
Well, that wouldn't be me then. I would make the comment, though I think a lot of the work needs to be done in the space between Nick and Tracy in terms of knowledge translation, in terms of tools for clinicians, in terms of information packages for Canadians in general, exploiting the tools that Canadians use. Look, we have a lot of smart people, including Nick, in Canada doing a lot of smart things, connected to a lot of smart people doing a lot of smart things outside of Canada. And I think most of us recognize we just haven't nailed how we can make it easy to use the products that we're developing. And I say that specifically, for example, in terms of some of the CatMap products I've worked on in the past, is how do we get that information, which I think is really solid analysis, into the hands of people that can provide advice in the case of clinicians that makes sense when they're dealing with a lot of people every day, and as well to Canadians in general. And I think that's the challenge. It's for sure, like Nick says, some capacity building is necessary, but a lot of it's about using the capacity that we have more wisely, in my opinion.
I would say that there are also a number of, there are a lot of initiatives by colleagues in other parts of the agency who are involved in trying to do exactly that sort of thing, Steve. So, it's not easy, but they're doing a fairly heroic job at it.
I agree, and it's the same thing. We're really trying to work on that in CatMat and some other groups among Nick, and it's hard. And part of it is it's hard because we're not the people that are good at it, and so it's involving the right people who are good at that kind of thing, such that we can work together to develop materials that are actually useful and accessible and used.
Perfect. Well, I just want to say thank you so much to each and every one of you for taking time out of your busy days to be a part of this panel. I think your insights were fantastic. And thank you again for being a part of this. I hope, and thank you for attending. I thought some very interesting discussion points. We're happy to take questions for the next couple minutes, but before we do that, I just want to say thank you to our panelists, Tracy, Nick, and Steve. Thank you so much.
Thanks for asking me to participate.
Yes, me as well. Was it great?
Wonderful. Thank you so much. Another great and engaging session. And a huge thank you to all of our panelists and moderators today. There are a couple questions in the Q&A, and we have about 3 minutes. I don't know, Ajit, if you would like to address any of those, or I can read a couple out.
Yeah, I think Tracy addressed some in the chat. So it's sort of pharmacist scope, which I think excellent responses to that. I did see there's a question here. Are there any links or info sheets that are available? I think that's sort of the education side and the access side. The question that came up.
I mean, a lot of the conversation has been around Lyme disease, and I'll just speak at a national level, and I'll speak for Nick because he works at the public health agency. I don't, but they have fantastic resources and they're improving. And so, I mean, you go to Dr. Google, type in Lyme disease in fact, and in pretty short order, you'll have some really excellent materials on Lyme disease, and they're improving and they're expanding the targets for those materials to include other pathogens potentially associated with ticks.
And Government of Ontario site has lots of great information that I imagine comes from public health, but it's a good source of information as well.
I hadn't thought about it, but I mean, if people have specific questions, I'd be happy to share my my email, you know, and I can probably be found wherever, but feel welcome to shoot me an email is my point.
Absolutely, yes. And any attendees can also email myself afterwards, and I'd be happy to get you in touch with any of our speakers, panelists, presenters from the last 2 days. So again, thank you so much. We're